our routine is Cefixime,
I know.
and if you have some other preference, we can change it.
My worry is that ESBL, E. coli came up in microgen. I know it's not 100%, but I guess it's more information than I had before. And that antibiotic doesn't cover the...
It's not proven, of course, nobody knows, but it may be a little weaker.
Yeah.
So if you want, we can use like levofloxacin.
I can't have any of the Flox family because it caused me.
And if cefuroxime is good for you, we can continue with cefuroxime.
Okay. But I also was aware that cefuroxime I wasn't 100% better, so it wasn't covering something. So I've read that nitro and fosmicin are better for ESBL.
Actually, they are they sound like this. They are said to be effective, but they are weaker antibiotics.
Yeah, I know they're weaker.
So maybe it's better to use them as a combination. Nitrofurantoin together with Cefixime, maybe a better idea, and the phosphomycin may be kept as a feature.
Yeah, and you can give me spare ones because I'm in a country where I don't have healthcare. Yeah, I'm in Lisbon and I don't currently have into the health system.
Sure, we can use some spare antibiotics.
Okay, so can you also, I don't normally take Hiprex, but can you subscribe me Hiprex as well? Yeah. I don't want to take it because I know it creates formaldehyde in the body, but maybe I could have like 3 or 4 months just in case. Because it's hard for me to get in my country. Okay, I'm thinking, I know that I saw on the group about ozone therapy. Is that something you recommend?
Yeah, I usually don't use it initially. If there's somebody who is not responding, and after 3 months we use it. And actually you can use it afterwards in Portugal if it is needed, and it must be given at least 6 times. So weekly 6 times.
6 passes a week.
Yeah, no, weekly for 6 weeks.
Oh, weekly. Sorry, so like once a week.
Yeah, once a week.
Is there any recommendations like is it best IV or is it
IV or rectal? Rectal is okay.
Rectal better. Rectal. Okay, and then based on that, is there anything else I should be doing to help my recovery?
Yeah, we will give some supplements, and you will use them for 3 months. It's usually okay. After 3 months, if you still have the symptoms, I will ask you to continue with Hiprex or nitrofurantoin.
Okay.
So I usually spare them for future use. If you respond nicely at the beginning, don't use them. Just use the supplements. Then if it's not going as you want, if the response is not enough good, you can use the Hiprex or nitrofurantoin.
Okay, then maybe I'll take 6 months of Hiprex just in case, because I'm conscious I can't get it where I am. Okay.
Still, it's better to give as some time, for example, 1 month or 2 months to see if, because usually my patients in Turkey never use these continuous treatments, and their responses are far better.
I don't want. I want to only use natural.
Hiprex, it's also a chemical which makes chemical fulguration.
I know. I don't
so
like
if you don't have it, because your symptoms are not too bad.
Yeah.
And if you are responding nicely, just better to not use anything.
Okay. Is there anything that I can be doing outside of this, like to help me heal? Like I'm thinking like I'm going to use like red light therapy, things like that.
We have no experience.
No experience. Okay.
But it sounds good. It has no side effect.
No side effects.
You can try such things, but there are many therapies like natural healings things.
So
we have no experience.
Of course. Okay, and I know you mentioned that because I took so many antibiotics before, so I was on levofloxacin for 7 months and it really affected me, and then limecycline. When I now do the fulguration, my question is, does the fulguration help the antibiotics like perform better? Because that's the problem I had before, that they didn't make it go away. But in my mind, scientifically, you're removing the biofilms, the leukoplakia. So does that mean they have access to places they didn't have before?
Yes, and the embedded infection will come out.
Okay.
And most of the time, our main aim is to finish it 100% completely. But sometimes if there is some remaining infection inside, they will be bare, and the antibiotics can touch them better. So, but the main aim is to remove them totally, and there will be no need for antibiotics.
Okay, so in the future, if I had another UTI, because we will still get UTIs, right, as women sometimes, right? Does that mean like a standard course of 5 days should kill it, right? Okay.
A couple of infections usually occurs in the first year, 1 or 2 infections, but they are easily treated.
Okay, and then so in Harley Street, where I was seeing the prof before, basically he uses the diagram, which I'm sure you've seen, of the bacteria bedding down. So my question is that, okay, so I've seen a lot of your videos of the fulguration, and you obviously do like the loop on the, I guess, like top-ish layers, but how do you access the bacteria that
I do a superficial fulguration. Sometimes I see a healthy, fresh, bare tissue coming out at the base. Sometimes I don't see it, just the irregular tissue at the top becomes burned, but the penetration deepness of this device is always the same, a couple of millimeters. And even I see a bare, fresh tissue, I am more happy, but the results are not related.
Okay.
Sometimes such a lady has a less successful result, and a lady which I see just the tissues become burned, fulgurated, but they didn't disappear completely, may have a better result. So the penetration of the fulguration is maybe 1 or 2 millimeters, and we will just superficially fulgurate and it will penetrate into 1 or 2 millimeters. We are never certain that it is totally gone or not, but it works.
Yeah, so there's no like
I can see it, I can say I have to go deeper in this lady.
Like you can't see like what's further down. Yeah, okay.
I can't see it.
Yeah, because I know that's his theory, is that they go really deep into the bladder walls, but then I guess it's like, how do you get them?
Yes, it's only my practice and experience says that in Turkey 80%, in foreigners 70%, it is working.
Yeah.
So this is a result.
So actually maybe the science that they are looking at is different, because like you've had such good success.
I tried in some of them to make deeper. If they didn't respond, I tried to make deeper. Sometimes it works, but initially I can't do it because the bladder is getting thinner.
Of course, and then it's even more prone to infection, right?
Okay. Not prone to infection, but the bladder wall vents become thin. If you make more resection, you can make a hole in the bladder wall.
Oh God, don't want that. Don't want that.
So we will always do a superficial cover.
And then let's say today we go in, I go for fulguration. Do I now then come back to you in 6 months' time and we look at the bladder again? What does that?
If it is not needed, it is not needed.
Yeah.
If you are good enough, no need.
Yeah. Okay. And you think with my case, based on the fact I haven't taken antibiotics for 3 years,
that's a good thing. And if it will be obvious in the procedure, if the bladder walls do not bleed, it's a good sign.
Okay.
If they bleed from everywhere, the healing will be longer. Maybe you will need some intravesical installations. Nowadays, I am using this therapy in my Turkish patients. If there is bleeding in the bladder walls, I give them some hyaluronic acid installations to cover the bladder wall. If such thing happens, we can discuss this.
Okay.
But if it is not happening, no worries.
Okay, so until you see it, you just don't know. I'd like to be awake. Is that possible?
Yeah, ask Musa, and you will communicate with the anesthesia team, and you can say your preference.
Okay. Yeah. Okay. I think that's everything. Is there anything else I haven't asked?
We will, everything will be seen in the procedure,
Okay.
and we will discuss the situation. It's better you be awakened, and we will
Ciao.